We specialize in seeing kids and adolescents with selective mutism at Thriving Minds, which is the clinic that I own. Caitlin runs the selective mutism program there. We do regular treatment and intensives, which are super fun for kids and adolescents. And then we do the Confident Kids Camp, which is running July 29th through August the 2nd here in Michigan. And we do have a teen classroom in that camp, which a lot of camps for selective mutism don't necessarily have a teen class. So we're excited to be able to provide that for teenagers as well. Really, we're going to be talking about how selective mutism develops and the impact that it has on teenagers and young adults. And then we're hoping to impart some assessment tools and strategies specifically for working with teenagers and young adults. So just to give you kind of some background information, as you probably know, selective mutism is a specific anxiety disorder. And so it is a little bit different from social phobia, even though there's a high correlation and a lot of overlap diagnostically between the two. I think it can be thought of as sort of like a specific phobia of speaking or communicating, which obviously social anxiety also has a piece of that. But for kids with selective mutism, sometimes they might not look socially anxious. They might be happy to be the center of attention. They might be standing on the front row of the play that they're giving, but it's really the speaking and communicating piece that can be challenging for them. The fear of speaking happens particularly in social situations. So school is really challenging for them, but also the community as well, right? So doctor's appointments, extracurricular activities and sporting events, family members, external family members, family friends can all be challenging to talk to. It's not due to a primary language disorder, but it is very co-occurring with language disorders. And depending on the research that you look at, it could be 35 to 75% of kids with selective mutism have a have a language disorder that might be complicating the picture as well. And then other things like stuttering or autism have been ruled out as the primary cause of the lack of speech or the decline in speech. That doesn't mean that you can't have autism and selective mutism. There's some debate around this of, is this a disqualifier, this criteria? Does it disqualify a kid with autism from having selective mutism? And I think most of the people in the selective mutism world say no. Kids with autism could potentially have selective mutism, but there has to be a difference between the way that the child is producing speech in the home setting and then the way that they're producing speech in the school setting or out in the community. There has to be a big discrepancy between the two. Some common misconceptions that we regularly see about selective mutism, I feel like on social media, this kind of stuff comes up a lot. One of the biggest ones is selective mutism is caused by trauma. We just don't find any kind of causal relationship between abuse, neglect, trauma, and selective mutism. That doesn't mean kids with SM can't have trauma in their background. Some do. What it means is that we just don't tend to see that this is a causal relationship between the two. But I think that a lot of times in the general public, that's the maybe incorrect assumption that these kids have been traumatized and that's the reason why they're not speaking. And instead, all the research just points to anxiety as being the driving factor in selective mutism, which obviously has heredity pieces to it, biological pieces to it, learned components to it, but not a trauma background. Sometimes we'll hear things like, oh, they'll just grow out of it. If we just make them comfortable, they'll grow out of it. As they get older, they'll grow out of it. And we don't necessarily find that to be the case either. And so we encourage people not to wait because early intervention is so effective and obviously has a lot of research behind it. Sometimes people will say that the child is choosing not to talk, and that can also be frustrating as well, because then particularly people at school or sometimes even parents will feel like this is a sort of like a malicious choice that the child is making, and that can make them very frustrated and reactive. We don't believe kids are choosing not to talk. We believe that they're overwhelmed by the anxiety in the moment. And then the last misconception is if we just reduce their anxiety, they'll be able to speak openly. And we just don't see that either. There are a lot of kids that we work with, kids and teens that we work with, where at school, they love their teacher, they have good friends, they seem comfortable in the school setting, and yet they aren't speaking. So it's more than just we reduce their anxiety in a given setting and somehow they're going to magically be able to talk. We know that there's an avoidance cycle that is learned and accidentally reinforced, and that is really important in maintaining the selective mutism, and that needs to be addressed. I think there's somebody on who may not be muted. Martha, I think you may not be muted. So a little bit of feedback's coming through.
I'm going to take over. I was just also going to offer a quick reminder that Dr. Quarterbutt and I are happy to take questions in the chat as we go. So for those who joined a little bit later, might not have heard that announcement. Sharing regarding prevalence. So I'll share a couple of statistics. One is that we have discerned that about 1% or so of school-age children present with selective mutism symptoms. That is probably higher than many of us would have expected. And certainly we think about many school environments, they have more than 100 children. So that means many schools have an individual with SM in their midst that they might not have recognized, might have thought of as shy or socially anxious and hadn't really attributed to selective mutism specifically. And we do know that there's less of a prevalence in older individuals with selective mutism. So this is not an incredibly heavy research article, right? This is a dissertation work, was informal Q&A from individuals who experience selective mutism. But the Sutton 2013 dissertation work suggests that about 1 in 2,400 young adults will experience selective mutism. So there's some changes across the lifespan. And to Amy's point just a minute ago about avoiding treatment or saying that someone will just grow out of it, that same article indicated that the window of time between, I think it was 12 and 16, the individuals endorsed that was the most challenging time for their SM symptoms, that they were most anxious, most uncomfortable, exhibited the most difficulty. So certainly, again, advocating for the earlier that we can treat, the better. We also know that about 2 females for every 1 male will be diagnosed with selective mutism. This is true of many anxiety conditions, but perhaps slightly different numbers with SM specifically. I did link this QR code. This is an ongoing research study from the team down at Florida International University, and they are looking at a longer term sort of prognosis and outcomes associated with SM. So if you have individuals that would sort of meet the criteria for that, for participation in that, we'd encourage you to pass along that information. We advance the slide. Whoop. Thank you. So this is a graphic that just is intended to highlight that we know SM is related to a lot of different things per the research. So like other anxiety conditions, there's a strong genetic component. We know that behavioral inhibition temperament or traits is especially common in individuals who go on to develop selective mutism. We know that there's that overreactive amygdala and some of the other emotion regulation systems in the brain. Of course, we know there's the environmental component as well. We're going to talk in a bit more detail about how this specifically develops and is maintaining the SM symptoms, but just a quick preview that we expect that there are some components of modeling of the anxious behavior that the individual might be seeing in their parents, extended family members, siblings, etc. We know that there might be some personal stressors. So for instance, like changing of school environments, or somebody calling a lot of attention to their speech and language when it was something they were already sensitive about. And then this idea of rescuing or making something so simple for them, or removing the expectations altogether, so there are no expectations for speaking. And again, we'll come back to that in just a minute. And then lastly, we have a sense that individuals with SM have an increased sensitivity to verbal interactions, and there's a number of potential variables at play there. We've referenced already that speech and language concerns are highly co-occurrent with SM. So it might be one of those, that the individual has an articulation disorder, let's say, and is as a result a bit more sensitive about how they speak and how others perceive what they're saying. SM is also more common in multilingual populations, and there's sort of a growing recognition that it's not just the language component, but also the acculturation level. So how immersed is the family unit in the new site and some of the community programming and school-based activities and things of that nature? Or are they predominantly interacting with individuals from their same culture and background and their same language? And then lastly, there's some research to indicate that there might be some differences with the way that the individual perceives their own voice through their inner ear. So a lot of different components at play here. And of course, the byproduct is SM. So I referenced just a second ago that the environment or the specific experiences of the individual are hugely important. I am also getting some feedback now. So if you're not on mute, please mute yourself. Thank you much. Speaking about this avoidance cycle, so you'll see here on the slide up at the top that the individual is prompted to speak or engage, and they fail to respond. They avoid because of that surge of fight or flight hormones and sort of all of the discomfort that brings at a physiological level. They avoid. And then inevitably somebody rescues. So for instance, we can consider a teenager in a classroom environment. They're called on to contribute to the lesson. They fail to speak. And at some point, the teacher moves on, calls on another student. Or a young adult is out to a restaurant with their family and they're asked to give their order. They don't respond within a short window of time, and their older sibling indicates their menu choice. So someone speaks for the individual, and everybody in this exchange feels better. Certainly the individual who is experiencing SM feels better because they've successfully avoided the thing that they were so anxious about, talking to that new person. But the others in the exchange are also reinforced for jumping in and speaking for them, because it's uncomfortable to sit in silence. It defies social norms to hang out in silence for so long. It's uncomfortable to see somebody else uncomfortable. And inevitably, we all feel better when we speak for them. And then, of course, this only perpetuates the pattern. It's incredibly successful in the short term, but in the long term, it means that this is the primary mechanism that the individual has learned to manage that discomfort, their anxiety. And so it is repeated and repeated and repeated and repeated. And this is not untrue of other anxiety conditions, certainly, but I think we would argue that it's perhaps the rate or the frequency with which this happens that might create a more deeply ingrained pattern of responding, or lack of responding, I should say. One other article to highlight here, we have in recent years been having more of a focus in the literature about what are sort of the content of the worries that individuals do endorse when they're speaking about their SM symptoms. And you'll notice that there's a ton of overlap with social anxiety sort of content, right? So we see about 67% of the worries that were reported. Of course, individuals could type in their responses. There was options, so it wasn't dependent on verbal interactions, right? But 67% or so of the worries endorsed fit under this umbrella of social fear. So fear of negative reactions or social evaluation, the fear that someone would notice their anxiety symptoms or the sort of expectation for a maintained interaction, things of that nature. But some of the more unique ones to SM are perhaps those voice-related fears here at the bottom, and certainly less commonly endorsed at 7%. But specific thoughts about my voice sounds funny, or people are going to judge the way that I am talking. There's, of course, this also a language-related fear with 12% or so of the worries endorsed, where they're focused on how am I going to be understood, my grammar, my pronunciation, the correctness of what I'm saying. And then, of course, the second most common, 40% endorsing fears of making a mistake. So again, I think these are pretty common that we would see in social anxiety as well, but really helpful, because one of the downfalls of working with individuals with SM is upfront, it is hard to get some of this content, some of their specific worries, experiences at the onset of treatment.
There was a recent research study that looked at the symptom severity in selective mutism and how it presents in kids and teenagers. And they sort of identified two different profiles, one being what they called low profile selective mutism. So for these kids, the fear of disapproval outweighs their fear of talking. Therefore, they might present whispering or speaking quietly. They may be the kind of kid that if you got them if you pulled them to the side and they were familiar with you and you asked them a very specific question that they knew the answer to, they would respond to you, but it might be the shortest response that they could possibly make, or it might be very quiet. But there's usually not initiating. There's not spontaneous speech. They're not advocating for themselves necessarily. There's a lot of well-intentioned professionals that exclude selective mutism as a diagnostic consideration when the kids have this presentation, because the child or the teen might speak in the professional's office. That doesn't mean that they don't have selective mutism. They may be this low-profile selective mutism, where if put on the spot, they would give a response, but there's still a lot of anxiety surrounding it. Then you have kids who have what the researchers called high profile selective mutism. So for those kids, they tend to be entirely silent with certain people and in certain situations. We'll talk about contamination and what that means with selective mutism in just a few minutes. But for these kids, the fear of talking outweighs their fear of disapproval. And there was an interesting question that happened in the chat box just a minute ago asking about shy bladder, and I was discussing enuresis. So lots of times people will say, I don't understand why kids and teenagers with selective mutism would have an accident at school, because wouldn't that bring more attention to them? It doesn't make any sense. And the answer is, it doesn't make sense, except if you perceive it in this context where the fear of them asking to go to the bathroom or even communicating nonverbally that they need to use the bathroom outweighs the fear that people are going to disapprove or attend to them. And so that's when you see these kinds of issues come up. We've alluded to in the past, we just don't have a lot of research on the way that teens and young adults experience selective mutism. And so some of this information that we have is sort of qualitative about what the experience is like. But adults with a history of selective mutism will report that like diagnostically, we would expect their symptoms presented when they were very young, but that they didn't find improvement or partial recovery until they were fully in adulthood, and that their symptoms were really severe and problematic in the teenage years. And I think that makes sense because developmentally, there's a lot that occurs in the teenage years. I'm thinking of going for a job interview, learning to drive, so taking driver's ed, participating in more advanced classes oftentimes includes like doing presentations and group projects and participation points, dating. All these like developmental milestones would be incredibly anxiety provoking for a teenager that was really challenged to speak. I think one thing to point out here that really sort of hits home with selective mutism in particular is that it does present when kids are very young. And so you can imagine when we talked about that avoidance cycle that occurs for kids that maintains the selective mutism. If that cycle began when they were 2, 3, 4, by the time that they're teenagers and young adults, that has been so well practiced by the teen. They have found usually amazing ways of getting around speaking, and so well practiced by the family, and so well practiced by the school that it's really, I don't want to say the word solidified because it's not solidified, but it's been highly reinforced over a decade at that point. And it's just more challenging to change, I think, because you're asking people to change a lot. Some of the specific impacts that you would see for kids with selective mutism in their teenage years, I'm not going to list all of these because you're capable of reading, but I think that some of the ones to highlight, the difficulty engaging with peers. Caitlin and I see kids when they're very young, all the way up to sort of young adults with selective mutism. And when you're in kindergarten, you can be friends with people and not talk to them. Like that's totally doable. You just play on the playground together. When you're a teenager and a young adult, you can't have friends that you don't talk to much. And a lot of times these kids in their teenage and young adult years, they just sort of fade into the background. And don't get the opportunity to develop a lot of friendships. They have difficulty with the initiation piece and advocating for themselves. And as they get older and they become more independent, there's an expectation, right, that they would be able to independently advocate for their needs, their wants, if they're sick, if they need help with something, and then participating in activities that would prepare them for young adulthood. So kind of these things that I mentioned, driver's training, job interviews, college applications and interviews all require a teenager or a young adult to be able to speak and speak fluently and manage their own anxiety during that time. And when a kid is challenged to do that, it would really get in the way of those normal developmental stages that we would expect to be a part of your teen and young adult years. Caitlin, did I miss anything before we talk about assessment?
No, but also I was monitoring the chat, so
But
if you did, I didn't catch it.
You did a great job, Amy. Thank you.
Yeah. Okay, talking next about assessment. You wouldn't mind advancing. Fantastic. So as a friendly reminder, things that are important to consider is differential diagnoses, social anxiety disorder. There's been some commentary here in the chat about trying to distinguish that low profile SM versus social anxiety. And so we'll chat just a bit more about some of the key differences. But we definitely want to make sure that we're doing a thorough job there. And autism spectrum disorder, because of course we have individuals who exhibit a lot of the language and reciprocal social concerns that are noted in autism. Of course, we see less from the restricted and repetitive behavior side of things, which would be one of the ways we would help to discern between the two. speech or language disorders. And then just effectively a friendly reminder here that as somebody is acquiring a new language, we do expect a normal window of silence. And so we just want to make sure that we're being sensitive to the fact we don't want to be overdiagnosing somebody when they're still working on acquiring a language. Okay, so there is a lot of overlap here between SM and social anxiety, and I've also lumped in shyness here too, because of course when we work with young kids, that's a huge question. Are they just shy? So tried to piece this apart as best as we could. We know that all three have some degree of genetic predisposition. We know that all three have that behavioral inhibition trait that is known and recognized quite early. And of course, there are environmental variables at play for all three that sort of perpetuate the sort of discomfort in public or social situations. So individuals who are shy, they one key thing though is that they're sort of reserved across all settings. They're slow to warm, but they do warm, and there's sort of limited functional impairment. Okay, so individuals who have social anxiety, of course, there is that functional impairment, and we know that there's the anxiety in situations with nonverbal and or verbal expectations, and lots of endorsing of fears of judgment and embarrassment. The warm-up time that might be necessary for an individual with social anxiety might be longer than is sort of feels typical or comfortable for the other communication partner or the social partner. And there's also the sense that the social situations are either avoided or endured with really intense fear or anxiety. And then one other keynote, Amy just referenced a little bit ago, that SM symptoms are really common when we see them first appear in very young childhood. And so we tend to see social anxiety symptoms more commonly manifest in that adolescent or pre-adolescent window. So I look at that list and I think, man, a lot of those sound like our individuals with selective mutism too. So a couple of additional points here that they're individuals with SM in some ways feel like they are two entirely different people, depending on where they are or who they're with. So they are sort of like frozen and not engaging, barely making eye contact, looked physically pained to be in a certain space. And in their home environment, they are loud and gregarious and outgoing, and sometimes you can't make them shut up, right? They talk so much. There is this sense in the SM world of contamination, that the longer the individual goes without speaking with a certain person or in a certain place, the harder it becomes for them to start speaking with that person or in that place. And so this sort of defies that, the more that you warm up, the more that we make them comfortable, they'll get, it'll be easier for them to speak. So really what I would say here is effectively, if there is somebody that they are failing outright to speak with and have really struggled to speak with for quite some time, we should be really considering selective mutism in addition to or as a replacement for the social anxiety. I think Dr. Cordoba mentioned this earlier in the presentation, but the nonverbal aspect for some individuals with SM is a non-issue. They are happy to go up to the front of their class and draw out the math problem on the, while everybody is watching them, or they are fine to present an advanced, dance or gymnastics or sporting events where all eyes are on them, don't even bat an eyelash at that. So it is very narrowly focused on the communication, verbal communication component. And there is some research that there is more of the behavioral inhibition trait that is observed in those early infancy and toddlerhood years in individuals who go on to develop SM than those who go on to develop social anxiety. So there's perhaps some sort of room for, in fact, there's some folks who actively endorse that this is really the same condition, but perhaps on a continuum. I don't know that we could say that conclusively at this stage, but certainly that's an interesting thing to note. As a friendly reminder, though, social anxiety and SM are highly comorbid, at least from the SM side, with 69% of individuals with SM having also meeting criteria for social anxiety. With regard to assessment, these are probably things that are part of many of your assessment processes anyway. Of course, we need a good clinical interview. We also think it's really important to see the individual sort of live. With regard to speech expectations, I can tell you a bit about our direct observation process in just a quick second. Skipping ahead to the behavior questionnaires, though, there are a couple that focus specifically on selective mutism symptoms. The only one that is age appropriate for our adolescents, teens, and I guess the very bottom end of the young adult group is the Frankfurt scale for selective mutism. This is normed for 12 to 18. But importantly, it was normed for the German population. It's been translated and we're using it in English, but just a note there. But what's great about it is the Frankfurt scale for selective mutism is it does have a lot of questions that are, much more narrowed in onto communication demands that are age appropriate for 12 to 18-year-olds. So, do they speak at their job if they have a job? Would they speak with all or just some of or none of their instructors? Things of that nature. And the Frankfurt scale for selective mutism does have some norms that suggest these are what individuals with SM might look like. These are individuals with just social anxiety, what they might look like. This is what an individual with other manifestations of anxiety might score on this particular questionnaire. At our clinic, we also use the SCARED, the RCADS, and which is great because it includes the depression sort of screener. For obvious reasons, we have limitations in communication where in the age group where we might see depression sort of set on anyway. So it's nice to be able to at least briefly screen for depression and certainly follow up if warranted. And we also use the BASC. So with regard to the direct observation, we have sort of a pretty established protocol that we use for young children, that the family will be alone in the playroom for 5-10 minutes. There's a camera system set up, so we're able to get a sense of what their language looks like at baseline. And then somebody new physically joins the space, but busies themselves, right? So I just got a really important email. I'm looking forward to playing with you. Hang on, do I have to answer this email? Or they have to clean up the space or something. So they're physically present, but not placing any speech expectations. And then the next condition is they start to ask questions. Of course, we want them to ask a variety of types of questions, so that way we're able to get a sense of what types of questions are more or less likely to elicit verbal responses. And then there's sometimes a condition where they're alone with that new communication partner without sort of the crutch of their parent or other comfortable communication partner, able to rescue or speak for them. They might do better, might also be harder for them. It's important information for us clinically as we prepare to advance into treatment. And then a return to baseline condition. How long does it take them to resume more typical speech patterns once they are, sort of decompressing a bit from that new person's presence? With a teen, we would probably do this in a modified way. So I've had individuals where I've set them up in sort of like more of a conference room area to like, I want you to work on your questionnaires over here. And I've had our office staff pop by and sort of like walk by a couple of times or organize something on the side to sort of recreate that scenario of like the new person is physically present, but not placing any speech expectations. And then I've maybe come by a little bit later to ask how they're doing on those questionnaires. Are there any questions? Can I get them a drink of water? Sort of those types of questions to see if that new person asking questions, do we get a verbal response or do we not? So that might be some of the modifications we might make there. And if the individual is school age, it is really important to get the school's input. I speak with a lot of parents who will say, I don't have any idea what's happening in my teenager's school. The kid has 7 teachers, it's probably different class by class. So being able to speak with the school counselor, or to have, a more informal mechanism to sort of solicit that input from them about, does the individual speak, and sort of under what circumstances would be appropriate. Some of the key interview questions, if you're thinking SM is a possible, on the table in terms of differential, that you might want to focus on are sort of the ins and outs. Who, what, when, where, how, and why are they speaking? So who do they already speak with, and who will they speak with kind of anywhere, right? No matter where they're at. Who do they not speak with? Again, it's important to assess for individuals who might be contaminated, where they're not speaking, period, and they have never spoken with that individual. And in what circumstances might they speak? Again, trying to bridge a little bit of that gap between what might be SM versus what might be social anxiety. So do they speak only if they need something? Only if they are asked to respond to a question? Can they give just sort of one word answers? What if they need assistance? Could they get someone's attention? Could they speak if they were one-to-one? Could they speak if they were in a small group of individuals? Do they speak with their peers, but not any sort of authority figures? Where are they speaking? Do they only speak in their home environment, or, their sort of places where they spend most of their days? Will they speak to their family member or comfortable communication partner in your office? That is one of the questions we try never to forget. Would they likely speak? Do you expect that they would speak to you here in our office? And if the answer to that question is yes, that tells us a lot about what we have options treatment-wise. Again, how are they speaking or communicating? Are they using exclusively gestures? Are individuals at the school giving them that, right? Like, here's your notepad, write out your questions to the instructor. Are they using Google Docs, or will they whisper? Will they use a 1 or 2 word answer? Will they use a full sentence? Things of that nature.
All right. We'll talk about the evidence-based intervention for selective mutism. There's some extra writing on our slides suddenly, which cracks me up because it's totally something that I would do. I didn't do this one, but I would totally do that by accident. So the evidence-based intervention for selective mutism, per research, is behavioral therapy. And actually there's a lot of similarities between the way that we treat selective mutism and the way that you would treat social anxiety. There was a recent meta-analysis that looked at different behavioral interventions specifically to try to figure out like what is sort of like the secret sauce that people are utilizing in terms of treating selective mutism. And I can show you what he came up with. So this is the meta-analysis that was done. As you can see, there was really only two research articles included that had even like tweens, teens, young adults included, unfortunately, because again, there's just not a lot of research on teenagers and young adults. But you can see in the Merson article that there's a lot of overlap and similarity in the strategies that people utilize despite the different age groups. Esposito's kind of like out there because clinically we don't really know what Esposito was doing in that research study, but
they're an Italian group. We can't read all of their article.
But what we do know is that a lot of the overlap of rapport building and engaging the parents in school, doing shaping or stimulus fading exposures, doing community practices as well when possible, contingency management, and all of those things were really important regardless. So what we know with research is that exposure is that primary mechanism of change. It's the special sauce that really makes the difference. And obviously that's very similar to social anxiety. And so some of the things that this would include is the careful prompting of speech, stimulus fading, which is sometimes also known as sliding in. Very similar to what Caitlin was discussing a few minutes ago, where we're slowly introducing ourselves into an interaction and slowly prompting for speech instead of sort of quickly asking the kid a question as soon as they come into our office. Shaping is reinforcing successive approximations of speech. And if you want to know more about those two strategies, I don't think we'll have time to go into them extensively today, but this will be my plug for our book, that we have all the information in our book. And there's a chapter that's just specifically how do you create these same situations for teenagers and in graduated exposures. We use a skill set to elicit speech that probably many of you are already familiar with from parent-child interaction therapy, PCIT. We obviously alter it for the age and developmental level of teenagers and young adults. Some of the do's for that are we're giving labeled praise for talking, but obviously it's different than you would interact with a kid, right? So if a kid responded to my question and said, I like dogs best, I would like excitedly, oh, thank you so much. You like dogs. I love that answer, right? Or with teenagers and young adults, I wouldn't do that as excitedly, but I would still say like, ooh, good answer. I like dogs too. Thanks for letting me know. Reflecting what they say. So just saying back what they say, not in a weird way, but we do that, I think, in regular speech with people. So what you're saying is, or what I heard is, giving descriptions of what they're doing to try to provide some of the verbalizations in the interaction, asking forced choice and open-ended questions, and totally staying away from yes/no questions, because teenagers and young adults with selective mutism will naturally default to a nod or a shake of the head or a shrug if they have the opportunity to do so. Giving direct prompts to speak. So instead of saying, oh, could you tell me about your vacation, which would be an indirect command to speak, saying, ooh, was your vacation to Florida or California? So not asking it as a question, could you, would you, do you want to, but more just giving the direct command. And then waiting at least 5 seconds for a response. And sometimes I have to wait longer. And I think particularly when I work with kids or teenagers and young adults, I do have to wait longer at first, because they have had this long learning of, if I just don't answer, this lady will move on, this uncomfortable situation will be over, and I can get out of here. And so really providing them that space, both to be able to come up with their answer, because maybe they have an expressive language delay, but also it's sort of like a way of saying like, no, I really mean it. I'm here for this. I'm gonna wait for you to respond.
If you're wondering what this looks like in action, this is a great sort of flow chart to keep in mind. So up at the top, there's somebody has asked a question. I'll just use the illustration for today of, do you prefer fiction or nonfiction reading? And if the individual verbally responds, right, we want to be subtle, but note that we have in fact heard them, and nothing, bad or overwhelming occurred when we did hear them, right? So we would, oh, you prefer fiction. That's great. So do I, right? So just again, acknowledge and subtle praising, and sort of using the conversation to sort of naturally reinforce that exchange. If they fail to respond or non-verbally respond, right, hold up, find, or type out their favorite title, book title, or favorite author, or try to write out their answer to you, whatever the case is. We treat both of those in really the same fashion. They didn't sort of engage in the exposure the way that we were hoping to, and the way that we were prompting them to do so. So we would repeat the question with that 5 or 10 second lag time. So wait it out. 5-10 seconds is an incredibly uncomfortable window of time to sit in silence with somebody, and then represent the question. I think you might still be thinking or deciding, do you prefer fiction or nonfiction reading better? And if at the end of that point, they do in fact respond, fantastic, treat it as if they answered the first time, move on pretty quickly. If they fail a second time to respond with that 5 or 10-second lag, that's your cue that for whatever reason that question was too challenging. And that could be for a big variety of reasons. But we would want to have a plan B or a plan C or a plan D at the ready. So, for instance, one thing that pops up in my mind is if I've asked the question fiction or nonfiction and they don't like reading, period, they might not volunteer that information, right? So I would perhaps want to give a secret third option, which is, or you're not really a reader, or is it you like both, right? So I could modify my question to include those options as well. I might also need to give consideration to who's nearby. So if we were in a coffee shop and it was just the two of us, but now there's a group of peers that are approximately their same age who are walking in, just as I asked that question, yet that would probably do it in terms of why they've stopped verbally responding or engaging. And so I might need to consider, well, we'll wait till they get over to the, to the line and they're sort of outside of our line of sight. So a plan B or a plan C, so they're never sort of off the hook entirely. Now, keeping in mind that because we're speaking with teens, you can advance the slide, Amy. Because we're speaking about working with teens or young adults, this would all have been spelled out for them in advance, right? So we're not saying to our teens, like, I'm just going to put you in these situations. You can have no idea. I'm just going to make you talk, right? That's not how exposure would work. We want to make sure that we're as transparent as we can be. In fact, with a lot of the teens that I work with, I will sit down and spell out for them fading in. This is what fading in looks like. This is what shaping looks like. I'm going to leave you with your comfortable communication partner who came to the office with you today. I'm going to leave you for 5 or so minutes. I just want you to think about it, talk about it, see if you have a preference between the two. If you don't, my preference is this, and here's why. So that they have the chance to really be an equal partner in terms of setting up what's going to be most effective for them to have success verbally. How can they engage in exposure? What mechanism do we have if something is too hard for them? So we don't sort of overdo it. We want to be really validating, right? Recognizing that we are asking them to face their worst fear. So being as validating as we can be is, I think, incredibly important. And using the psychoeducation that we have in a developmentally friendly way. I think one of the things that is really important is the confidence that we as clinicians carry, this sort of like calm confidence that I believe that you can do hard things. I know this is incredibly challenging, and I believe that you can persevere. That has to be sort of matched in our tones and the language that we're using, right? Some of the teens that I've worked with, I've had conversations with parents where they've said, I brought my teen to this school, like after school event. It was like a party or dance or some sort of after school program. And I knew they were really overwhelmed. I told them, I believe in you. I told them, I think you can do this. And then I sat in the parking lot just in case they needed to leave, right? Like that was something that was subtly communicated to that teen. And of course, the second the text message came through, I want to leave, that parent was right there ready to go. So the confidence that we exude has to be matched in the way that we're prepared to support them as well. And then we've referenced this sort of careful use of praise. We don't want to be too over the top about it with anybody of any age with SM, but certainly not with our teens. With regard to psychoeducation, everybody, I'm sure on this call has their own way of doing this. Some of the things that we really like to highlight are the neurological components, the fight or flight response, why it happens, how it's really functional, and really important that our bodies protect us in this way from truly dangerous situations. But of course, some folks' brains make the anxiety alarm, the danger alarm go off in uncomfortable but not dangerous scenarios. And, our hope is to be able to help them discern between the two. We share that avoidance feels like it's the simplest and most effective way to manage anxiety, but especially with tweens and teens, they have been avoiding for quite some time and have probably ample experience where it tends actually not to work that way. It's not actually reducing anxiety in the long run. I'll just share that one of the things that I find to be, especially, I pulled this from a talk several years ago that I attended, and I can't even give credit to it because it was so long ago, but they shared that they use a sour candy to talk about exposure work, that it's going to be really sour and uncomfortable at first, but if you stick with it, that warhead that you have in your mouth, it's going to get easier and it'll get sweeter eventually. You just have to stick with it long enough.
So here are a bunch of exposure ideas that we've used with teenagers, and everybody's going to have these slides available after our talk today. So in the interest of time, I'm going to keep going, but here's some ideas that you can use. Some of the supplementary strategies that we would use with teenagers and young adults, contingency management. So having some sort of oftentimes privilege-based, but sometimes also tangibly based reinforcement system paired with this. Medication, usually SSRIs, are common, I would say, when we work with teenagers and young adults with SM. We do cognitive restructuring, but I want to highlight that the exposure piece does tend to be the special sauce. And at least in my practice, and Caitlin can speak for herself, I start with the exposure, and we get to the cognitive restructuring if necessary and is helpful later.
And it has to. I mean, they can't speak with you in the session. You have to do exposure to get them to that place. So yeah, for sure.
Obviously, motivational interviewing might be a part of this, because otherwise, why would I do this hard stuff if I don't see the benefit of it for myself down the road? And then we might need to do some special education planning, probably because the school has set up special education systems perhaps for this kid where there's a ton of rescuing happening by accident, maybe even accommodations that are too accommodating for this teen or young adult. So how can we help the school scaffold them towards more independence and more speech in school while still supporting them?
We probably don't have time to go into much detail here. We wanted to give you a case illustration. This is a teenager, high school student, senior right now, who has a history of SM. She's one of my prior clients. I've worked with her sort of intermittently. In her middle school years, I did an in-school intensive. So I went into her school environment and actively prompted her with her full support and a sense to speak with her different teachers. So part of that occurred in one-to-one scenarios, right? We went to her class 5 minutes before the bell rang so we could have a private opportunity to speak with her teacher. And as we had some success with that, we worked here to increase the amount of people we were practicing with. In response to COVID, this teen's family opted for more of a educational pod. And so a lot of the momentum was lost. There was some great gains in that pod, right? She was doing like skits and like presentations and really incredible things. But when she transitioned back to the school environment, things became challenging again. But one thing that a couple of points here, just for this particular teen, there was an incredibly long latency for her to produce verbal responses. And so she did some virtual work and sort of the more traditional model of like, let's plan out the exposure and then you guys carry it out at home. But because of that really long latency, like the social opportunities often passed before she could actually work up the courage to say her piece. So for this particular teen, like being present with her really was meaningful in order for her to actually get the exposure opportunities in and completed. Yeah, and then we do have a few additional resources here. Some from John Kohlmeyer, who's one of our colleagues at the Selective Mutism Association. He's a young person who's overcome selective mutism. He's written a book. He's got some great videos online describing his experiences. He's a really passionate advocate for individuals who experience SM. We've included a couple of books here that would be age appropriate for some of your clients. Being Brave with Selective Mutism, which is from Dr. Rachel Bussman. And then can I tell you about selective mutism? The Selective Mutism Association has not only great printable resources on the website, but a really robust variety of YouTube videos on topics pertaining to SM. One to point out or to highlight is the Hear Our Voices panels. So these are individuals who've overcome selective mutism, describing their experiences and answering questions from the audience. And I think that can be really insightful and motivating and validating for individuals who are still in the midst of their symptoms, to hear people who, are a bit further on in their journey.
And then our last piece that we wanted to highlight is these families can be complicated to work with sometimes. So if you feel like I have one of these families, I'm challenged, we're plateauing, I'm not sure what to do, we do provide professional consultations for professionals, and we have trainings and workshops online and so forth at our website. So don't hesitate to reach out to us. We enjoy helping other people be successful in seeing kids with SM.